Hello students, welcome to chapter 67, Concepts of Care for Patients with Male Reproductive Problems. Remember, this chapter contains my comments in which I usually type "that's good to know." So those are parts and concepts that you need to remember. They are important for exams and quizzes. Okay, also I will recommend you to pay attention to your NCLEX challenge questions within the chapter and the mastery questions at the end of the chapter, and they are located before the references. Okay, I might take questions from this chapter, from the test bank of this book, but also from other books and other NCLEX review examination books. So, but the most important is that I personally make sure that all the questions, you can find the answers in this chapter. So I'm not going to test you on something that I'm not teaching. Okay? Just to make sure, 100% guarantee. Okay, so we are going to talk about, but let's start with the male reproductive problems are very personal and can range from short-term infections to long-term health care problems that require end-of-life care. Three conditions can affect the human need for sexuality, elimination, and reproduction, all of which can impact the man's physiological and psychosocial sense of well-being. So let's start with this video to open the topic. Okay, let's see.
If you have benign prostatic hyperplasia, or BPH, your prostate gland is enlarged. The prostate is a walnut-sized gland in men. Just beneath your bladder, your prostate gland surrounds your urethra, the tube through which urine and semen exit your body. Your seminal vesicles and prostate make fluid that combines with sperm cells to create semen. During normal urination, urine flows from your bladder through the part of your urethra inside your prostate, then through the rest of your urethra to leave your body. For unknown reasons, your prostate gland may enlarge as you get older. If you have benign prostatic hyperplasia, your prostate may grow large enough to narrow or block the part of your urethra that runs through it. As a result, your enlarged prostate may slow or block the urine flow out of your body when you urinate.
Thank you so much. So that was the video explaining benign prostatic hyperplasia, or commonly known as BPH. Okay, very good. So with aging and increased dihydrotestosterone, DHT, levels, the glandular units in the prostate undergo nodular tissue hyperplasia, an increase in the number of cells, and abnormal overgrowth of tissue. This altered tissue promotes local inflammation by attracting cytokines and other substances. But what is DHT? I want you to understand that, because most of the diseases related to the male prostate, they are having this component. So you need to be familiarized with this.
Dihydrotestosterone in BPH. Dihydrotestosterone, DHT, an androgen more potent than testosterone, is beneficial in the development of prostate, but can be detrimental in the adult prostate, causing BPH. The androgen signaling axis controls the development and maintenance of normal prostate, as well as development of BPH. DHT is a metabolite of testosterone, obtained by the action of a nuclear membrane-bound enzyme, steroid 5-alpha reductase, on testosterone.
Thank you. So those are the concepts that I want you to keep in mind. DHT is a potent form, androgen potent form of testosterone. And remember the 5-alpha reductase, okay? Because you are going to see an explanation about this when we talk about the drugs and the treatment, okay? So urinary elimination is affected in several ways, causing lower urinary tract symptoms, LUTS, low urinary tract symptoms, an umbrella term that includes problems such as urinary retention, urinary leaking, or incontinence. Urinary stasis can also result in urinary tract infection and bladder calculi stones. In a few patients, the prostate becomes very large and the man cannot buoy acute urinary retention. That is called acute urinary retention, when the man cannot buoy. The patient with this problem requires emergent care. In other patients, chronic urinary retention may result in a backup of urine and cause a gradual abnormal distension of the ureters, hydroureter, and enlargement of the kidneys, hydronephrosis. If benign prostatic hyperplasia is not treated, these urinary elimination problems can lead to chronic kidney disease, and we're going to talk about the kidney in the next chapters. Etiology and genetic risks. The exact cause is unclear of BPH. Its relationship to aging is the only known factor. Other unmodified risk factors include race, black men younger than 65 need treatment earlier than white men. Also, low urinary tract syndrome is more common in black men than white men. Genetic susceptibility, family history of cancer. Those are the unmodified. The modified risk factors, look at this: obesity and metabolic syndrome, which we discuss very deeply in the gastrointestinal part of the semester. Beverage consumption, coffee and caffeine intake have been associated with an increased risk of progression of existing BPH. And all these modified risk factors have a significant role in different diseases, inclusive when we mention salt related to the female disorders. Incidence and prevalence. Benign prostatic hyperplasia affects 40 to 50% of men between the ages of 51 and 60 and over 80 of men older than 80. Teach men that BPH is a common occurrence and that sexual frequency does not cause this condition. Current evidence does not show that there are absolute specific actions that prevent the development of BPH. However, teach men that addressing modified risk factors can improve their overall health. So remember, obesity, metabolic syndrome, and go and review your gastrointestinal so you can review the three conditions that needs to happen in order to have metabolic syndrome. Okay. Let's see, history. Several standardized assessment tools are used to help the healthcare provider determine the severity of lower urinary tract symptoms associated with prostatic enlargement. The International Prostate Symptom Score is a tool that is used very frequently. This tool incorporates the American Urological Association Symptom Index as question 1 through 7 and ask an 8th question about the implication of the patient urinary symptoms on quality of life. So here we have the International Prostate Symptom Score tool. You see the 7 questions. They are talking about incomplete emptying, and The score runs from 0 to 5. So you can say almost always. They are asking you about, they are asking the patients about frequency, intermittency, urgency, weak stream, straining, how often you have to strain to start urination. This question is, for me, is one of the most significant part in the assessment, because you don't ask this to everybody, to all male patients, unless they verbally express that they are having this condition. Nocturia, how many times do you typically get up at night to urinate? This is another very significant question. What happened here? Okay. So they are explaining here the assessment tool in deep. You're welcome to read. Physical assessment, signs and symptoms. Ask about the patient current urinary elimination pattern, urinary frequency and urgency, as we saw in the assessment tool. The times the patient awakens during the night to avoid nocturia. Assess for difficulty in starting, that's hesitancy and continuing urination. Reduce force and size of the urinary stream. Sensation of incomplete bladder empty. And I would say this is another good differentiator between BPH and other conditions. Straining to begin urination, another one that I will consider very important, is giving you hints of what's going on. Post-void, after voiding, dribbling or leaking. That's another one. I like these three. It's very important. It's very significant when you assess. This is talking about BPH. Okay. Here. Green, green, green. Okay, the patient is also at risk to develop an infection or other bladder problem. Hematuria, we know, blood in the urine. When starting the urine stream or at the end of voiding, BPH is a common cause of hematuria in older men due to infection. And first of all, in yellow, I have that's good to know. Nocturia can affect the sleep patterns, affecting lifestyle and mood. And this happens not only with people with BPH, right? When we don't have enough rest, we don't sleep the amount of hours that our body requires, we are going to have a significant change in our lifestyle and mood. And another that's good to know that is in green is talking about hematuria. At the starting of urine or at the end of voiding, infection means infection. Again, infection could be represented by hematuria present at the starting of urine or at the end of voiding. That's good to know. Okay. Remind the patients to void before the physical examination. Inspect and palpate the abdomen if the patient has a sense of urgency. When gentle pressure is applied, the bladder may be distended. Patient with obesity. So how many of them are feeling pressure in the bladder because of the adipose tissue, right? You have to start thinking. Critical thinking, nurses, develop that. Patients with obesity are best assessed by percussion done by the healthcare provider or bedside ultrasound bladder scanner rather than the inspection or palpation. Prepare the patient for the prostate gland examination, which will be conducted by the healthcare provider, of course. Because the prostate is close to the rectal wall, it is easily examined by digital rectal examination. The healthcare provider assesses for size and consistency of the prostate. BPH presents as a uniform, elastic, non-tender enlargement. And I'm going to repeat. BPH presents as a uniform, elastic, non-tender enlargement, whether cancer of the prostate gland feels like a stony, hard nodule. Cancer is going to feel a stony, hard nodule. Advise the patient that after the prostate gland is palpated, it may be massaged to obtain a fluid sample for examination to rule out prostatitis, inflammation, and possible infection of the prostate, a common problem that occurs with BPH. If the patient has bacterial prostatitis, he is treated with broad-spectrum antibiotic therapy to prevent the spread of infection. Okay. Psychosocial assessment. Patients who have nocturia and other lower urinary tract syndrome LUTS may be frustrated or depressed as a result of interrupted sleep and ongoing visits to the bathroom. And that's good to know. Again, I'm repeating, and the book is repeating again, something that is very interesting and important. And not only it will come in your test, since the book is putting is emphasizing in this, probably is coming in your NCLEX. Assess the effect of a sleep disruption on the patient's mood and mental status. Ask him about the impact on symptoms on sexuality and libido, sexual desire. Post-voting dribbling and overflow incontinence may cause embarrassment and prevent the patient from socializing or leaving the home. Yeah, it's very sad. Laboratory assessment and urine analysis and urine culture are typically obtained to diagnose urinary tract infection and microscopic hematuria. If infection is present, the urine analysis measures the number of white blood cells. If infection is present, of course, your WBC are going to be elevated. A complete blood count to evaluate any evidence of systemic infection, which is elevated WBC, or anemia, and that will be a decreased red blood cells, RBCs, from hematuria. Okay. Blood urea nitrogen, your BUN, and serum creatinine levels to evaluate renal function. A prostate-specific antigen, PSA, test for screening purposes. This test is for early detection of prostate cancer. A serum and phosphatase level if metastatic prostate cancer is suspected. Right? We always, when we suspect metastasis, we are going to run the test for phosphatase level. Cancer of any nature. This marker is going to be high. A biopsy, which may be performed if life expectancy is greater than 5 to 10 years. And if needed to confirm a histologic diagnosis, usually transrectal ultrasound, TRUS, or MRI is performed first. Culture and sensitivity of prostatic fluid if expressed during the examination. Yeah, I know you're going to ask me for a video. Imaging studies that are typically performed are the transrectal ultrasound, TRUS, more common in the US, and MRI, more common in other countries. A tissue biopsy may also be done during this procedure. Let's watch this procedure. How is it done? TRUS, transrectal ultrasound.
Your doctor has recommended an exam of your prostate with a transrectal ultrasound and prostate biopsy. Before we talk about this procedure, let's review some information about the prostate and why these tests may be necessary. The prostate is located under the bladder and behind the penis. It is a walnut-sized gland that is part of the male reproductive system. It helps make semen. The urethra is a tube that carries both urine and semen to the penis. It passes through the prostate, which surrounds it like a donut. If you are scheduled for this procedure, your surgeon is concerned that you may have prostate cancer. Prostate cancer is the most common cancer found in men. At most risk are men age 50 and older and those with a family history, especially a father or brother with prostate cancer. But at highest risk are African American men and men over age 70. Usually there are no early signs of prostate cancer, but some men have problems with urination or pain that warn a physician that more testing is needed. Prostate cancer screening can help physicians find prostate cancer early before a patient has problems and include the digital rectal exam, or DRE, where a physician examines the prostate for lumps by placing a gloved finger in a man's rectum, and prostate-specific antigen, or PSA, is a blood test ordered for some men based on their age and risk factors. Routine PSA testing is not recommended after age 70. A prostate ultrasound with biopsies is done to test for cancer when a nodule or lump is felt. It is also done for a high PSA and for some problems, especially with urination, that can be a sign of prostate cancer. With an ultrasound, your surgeon is able to scan and measure the prostate without X-rays or radiation. The ultrasound also guides the needle used to biopsy your prostate. The tissue biopsies are sent to a pathology lab for examination. The next steps for your care are discussed after the procedure and with the final lab results. This may take 1 to 2 weeks. If cancer is found, the lab will give the tumor a number called a Gleason score, which is a grade of how abnormal or aggressive the tumor cells look. DNA gene testing is commonly done on the tumor cells as a new way to measure how aggressive the tumor is. This is different than a cancer stage, which is based on where, how large, and if the tumor has spread. Treatment decisions for prostate cancer are based on many factors, including a patient's age and general health, the cancer Gleason score, DNA results, and stage. A biopsy can be false negative. That means the biopsies did not find prostate cancer that was there. 30% of men with prostate cancer, about 1 in 3, will have normal biopsy results from the first procedure. A second procedure with more biopsies is done to search for prostate cancer if a PSA stays high and cancer is strongly suspected but was not found with the first set of biopsies. Sometimes MRI, magnetic resonance imaging technology, is used with the ultrasound to help find or target a tumor for biopsy. Ultrasound-guided prostate biopsy tends to be a short procedure, available at many hospitals, and is the most common procedure used to biopsy the prostate. MRI technology uses magnetic coils to get detailed information about the prostate and possible cancer. MRI is very expensive, takes longer to do, is newer and still being studied, is less available, but is helpful in managing difficult cases. Now let's talk a little more about what happens during a transrectal ultrasound and prostate biopsy. To start, you are positioned comfortably. Most patients are awake for this procedure. An ultrasound probe is coated with lubricant gel and gently placed into your rectum. The gel helps the probe to be more comfortable for you and is needed to get clear ultrasound pictures. The size and shape of the prostate is checked and measured by gently moving the probe near the prostate. Numbing medication is injected near the prostate to decrease the discomfort of the biopsies. The ultrasound probe is used to guide a needle biopsy device to take about 12 tiny pieces of prostate tissue. You will hear a snapping sound with each biopsy. After the biopsies, the ultrasound probe and needle are removed. This procedure is done as an outpatient. That means you will go home the same day as the procedure.
Thank you so much. And I really like this video because presents you the whole problem. It's talking about BPH, all the treatments and everything. And remember, practice makes perfect. So repetition is good. Even though you have it in the book, you see in the video, as many times and as you come across these concepts, you are going to remember, are going to feel more comfortable for tests and the NCLEX. You can use this video to when you are walking, when you are shopping, when you are driving. So you don't need the PowerPoint to be only doing one activity, reading. You can do review of the concepts while you're doing something else. Okay, very good. So let's go to improving urinary elimination. The patient with BPH is expected to have a normal urinary elimination pattern without lower urinary tract symptoms or infection. Non-surgical management, behavioral modifications to avoid drinking large amount of fluids in a short time, especially before going out or at bedtime. Caffeine and alcohol consumption should be limited as these have a diuretic effect. Also, they need to avoid drugs that can cause urinary retention, especially anticholinergics, antihistamines, antipsychotics, and muscle relaxants. They can cause urinary retention. Emphasize the importance of telling any healthcare provider about the diagnosis of BPH. So these drugs are not prescribed. They need to know, the PCP needs to know that these are medications that are contraindicated. Drug therapy, alpha adrenergic antagonist, which acts to relax a smooth muscle in the bladder neck, and 5-alpha reductase inhibitors. Remember I told you we were going to speak about this, which act to reduce prostate size, are often prescribed in combination as evidence shows that they work better in combination. So they are going to order one 5-alpha reductase, and they are going to also order or prescribe alpha adrenergic antagonists. Two commonly prescribed drugs regimens include finasteride, and doxazoxine, or dutasteride and tamsulosin. Okay, so here you have the table of all the medications. So here you have the alpha adrenergic antagonist, and here is your doxazoxine or your tamsulosin. You need to monitor blood pressure and teach to move slowly from sitting to standing because these are causing orthostatic hypertension. The same side effects is in the 5-alpha reductase. You see in green, monitor blood pressure, orthostatic hypertension can occur. However, and this is good to know about your alpha adrenergic antagonist, about your doxazine and tamsulosin. Monitor for side effects such as ongoing dizziness, headache, and weakness. These side effects may require dose reduction or discontinuation of the drug. Teach patient to report taking this drug to a healthcare provider. Can increase or decrease the side effects of other drugs such as beta blockers used for your hypertension, and also your calcium channel blockers as well for hypertension, or medication used to treat erectile dysfunction. Okay, so tell your PCP that you are taking this alpha adrenergic antagonist in case the patient is taking any beta blocker, calcium channel blocker, or medications for ED, erectile dysfunction. Talking about the 5-alpha reductase inhibitors, another that's good to know. Teach about possible side effect of gynecomastia, your dutasteride and finasteride. So gynecomastia, men taking a 5-alpha reductase inhibitor are 3 times more likely to develop this condition. Okay, 3 times. Teach about the increased risk for developing or development of prostate cancer. Men taking a 5-alpha reductase inhibitor are at highest risk for developing prostate cancer. So they are going to benefit for the BPH, but they are going to develop prostate cancer. Maybe. Teach to keep medications stored away from pregnant women or women who may become pregnant. You see the importance of this paragraph in yellow? That's good to know. This is going to come in NCLEX for sure. This is a safety concept, okay? These drugs are teratogenic and can be absorbed through the skin. Therefore, pregnant women should not touch dutasterate nor finasterate. Teach patient taking dutasterate to take the capsule with a full glass of water and to refrain from opening the capsule to sprinkle on food. Who is doing that? Dutasterate irritates oropharyngeal mucosa. Okay? It is specified here is because some patients are doing that. Amazing. Okay, so this is something you need to be very comfortable with because this is going to come one way or another, especially the teratogenic, right? In any exam. Then you have the tadalafil. You have to teach about the medication that is given to treat erectile dysfunction, but can also be used to improve lower urinary tract symptoms. So if the patient is taking tadalafil, right, do you think the patient can take tamsulosin or doxazosin that is, are having contraindications for patients that are taking erectile dysfunction drugs? Okay. Teach that the duration of action is up to 36 hours and to avoid taking more than once daily. Wow. This duration of action is much longer than the most phosphodiesterase inhibitor medication that the patient may have used in the past, which have only a 4-hour duration action. In terms of this category of drugs, I would say the most common, the most well-known is your Viagra, sildenafil. It's called sildenafil Viagra. The duration of action is 4 hours versus tadalafil that is working for 36 hours. Teach to refrain from taking this drug with grapefruit juice or grapefruits. Right? Drinking grapefruit juice or eating grapefruit while taking tadalafil can increase the amount of drug in the body. So then after taking your grapefruit, right, your half-life, the half-life of the drug is going to be less, right, or more. Anyways, the drug is going to be in your system for a long period of time. And that's good to know. Okay. Nursing safety priority. Remind patients taking a 5-alpha reductase inhibitor for BPH that they may need to take it for as long as 6 months before improvement is noticed. What is your 5-alpha reductase inhibitor? Your durasteride and your finasteride. The ones that are causing gynecomastia, the ones that are teratogenic, right? And the ones that are putting the patient in high risk for prostate cancer. Okay? And they are telling you that you need to communicate to the patient that this medication probably is going to be needed for a period of 6 months in order to see any benefit, right? Remind them to keep all follow-up appointments for laboratory testing because liver damage can occur. Teach about possible side effects included erectile dysfunction, decreased libido, and dizziness due to orthostatic hypotension. Remind them to change position carefully and slowly, and this is good to know. Okay, so you need that's the thing. Many patients with BPH, they prefer to monitor instead of getting into these treatments because of the side effects of the drugs. And probably, and they're right, right? This is no joke. These medications are very strong. Another nursing safety priority: teach patients taking 5-ARI to keep this drug stored away from pregnant women. We know that because they are teratogenic. Another nursing safety priority: drug alert. If given alpha blockers in an inpatient setting, assess for orthostatic postural hypotension, tachycardia, and syncope, blackout, especially after the first dose is given to older men. If the patient is taking the drug at home, teach him to carefully when changing positions and to report any weakness, lightheadedness, or dizziness to the healthcare provider immediately. Bedtime dosing may decrease the risk for problems related to hypotension. Okay, so that's basically the empiric, how the doctor will prescribe, the time that the doctor will ask the patient to take the medication. This empirically is basically how the doctor will manage. Low dose oral desmopressin, a synthetic antidiuretic analog, has been used successfully for nocturia. Complementary and integrative health. Saw palmetto is a herbal therapy, has been shown in some studies to be useful in treating BPH. However, other studies have demonstrated no benefit or benefit that is similar to placebo effect. That's why many patients first they prefer to wait and observe how the BPH is behaving. They don't want to get into these drugs, and they prefer to use saw palmetto even though there is not enough evidence-based practice with this medication. So it's up to the patient to decide what they want to do. Potential interactions with prescribed drugs such as anticoagulants and NSAIDs will occur. Side effects with saw palmetto, right, are rare and are usually limited to mild nausea and headache. Okay, other non-surgical interventions. Frequent sexual intercourse can reduce obstructive symptoms because it causes the release of prostate fluid. All right, this approach is helpful for the man whose obstructive symptoms result from an enlarged prostate with a large amount of retained prostatic fluid. Several non-invasive techniques are available to shrink or destroy excess prostate tissue. The minimally invasive prostate artery embolization is performed by an interventional radiologist who threads a small vascular catheter into an artery in the wrist or groin. Yes, the catheter can be inserted through the artery in the wrist or groin, and we're gonna watch this video so you can understand how the prostate artery embolization is done.
Prostate artery embolization, or PAE, is a non-surgical treatment for benign prostate hypertrophy that can improve symptoms with low risk for sexual side effects. The urethra carries urine from the bladder, but it passes through the prostate. When the prostate enlarges, it causes compression on the urethra and bladder, making urination difficult. This is called benign prostatic hypertrophy, or BPH. PAE can be performed from a single pinhole incision in the groin or wrist. A small tube is inserted into the artery, the size of a strand of spaghetti, and navigated to the artery that feeds the prostate using high-tech equipment. Once the location is confirmed, the blood flow to the prostate is slowed down using small FDA-approved particles that are smaller than a grain of sand. The reduced blood supply causes the prostate to shrink. This allows the bladder and urethral pressure to reduce and improved urination to occur.
Excellent. So my understanding is that the healthcare system first want the patient to go through all the diagnosis, right? All the blood tests, and then they put the patient in medication. And after that, if that doesn't work or something else, they can access the prostate artery embolization, right? Surgical management. For patients who are not candidates for non-surgical management, or are not interested in medication or other less invasive options, surgery may be performed. Some of all of these criteria indicate the need for surgery. So you have your acute urinary retention, people with chronic urinary tract infections, hematuria, hydronephrosis, persistent pain with decrease in urine flow. If a lesser invasive procedure is not indicated or desired, the historical gold standard surgery has been a transurethral resection of the prostate, which is known as your TURP, in which the enlarged part of the prostate is removed through an endoscopy instrument. Okay, so let's watch this video to see what is the TURP. Okay, I need to master this. Okay, let's watch this.
Your doctor will then lift your penis upward. A well-lubricated instrument called a resectoscope is then gently inserted into the urethra.
Oh my God.
When the resectoscope reaches the back of the penis, your doctor will pull the penis downward in order to create a straight path into the prostate. Once the instrument is inside the prostate, your doctor will extend a small loop of sharp-edged wire from the end of the resectoscope. Using this tool, your doctor will then scrape excess tissue from the prostate, restoring it to its normal size.
Oh, wow.
Tissue removed from the prostate may be sent to a laboratory for analysis.
They have to.
When the surgery is complete, your doctor will remove the resectoscope. Your doctor will probably ask you to wear a temporary Foley catheter. A Foley catheter is a narrow tube inserted through your urethra and into your bladder.
Bladder, yes.
The catheter is connected to a bag that is attached to your leg by a strap. While the Foley catheter is in place, urine will pass from your bladder into the bag. You will not need to urinate into a toilet. The nurse will show you how to change the bag when it's full. An appointment will be made for you to return to the doctor's office in a couple of days to have the catheter removed.
So you saw that's the TURP, transurethral resection of the prostate. Okay. Open laparoscopic or robotic assisted simple prostatectomy, entire prostate removal may also be considered. Okay, so preoperative care, regardless of the type of the surgery to be performed, reinforce information about anesthesia, remind patients taking anticoagulants that the drugs will be discontinued several days prior to the TURP for logical reasons, or open prostate surgery to prevent postoperative bleeding. I would say think about your diabetic patients. They are going to ask you to have a very nice A1C probably before the procedure. Other procedures used to treat benign prostatic hyperplasia. Here you have a complete list of procedures and you're welcome to read them. The patient may have other medical problems that increase the risk for complications in general anesthesia and may be advised to have a spinal anesthesia. Because the patient is conscious during a spinal anesthesia, it is easier to assess for hyponatremia, low serum sodium, fluid overload, and water intoxication, which can result from large volume bladder irrigation. Let me see something. Okay, so explain that it's normal for the urine to be blood tinged after surgery. Small blood clots or tissue debris may pass while the catheter is in place and immediately after it's removed. Some patients also have continuous bladder irrigation depending on the procedure performed. And continuous bladder irrigation. Here you have the graphic. You see is a big bag of isotonic solution that is connected to a port that has three pathways, right? So one pathway is the bladder solution that is going to enter and is going to irrigate the bladder. And the other pathway is going to remove the fluid with possible little blood or clots, and is going to be collected into this bag. Okay, and this is the port for the balloon insertion, inflation, right? So you have to write how many milliliters of isotonic fluid you use to irrigate the bladder, and then you have to compare that amount versus the amount that is being released through the other part of the port and is collected. So you need to make sure those numbers are correct, right? The fluid coming in versus the fluid coming out. Operative procedure. The disadvantage of a TURP is that only small pieces of the gland are removed. Remaining prostate tissue may continue to grow and cause urinary obstruction, require additional TURP. Urethral trauma from the resectoscope with resulting urethral strictures is also possible. The patient who had TURP may have a catheter and continuous bladder irrigation. We know that. For several days. For the continuous bladder, a three-way urinary catheter is used. We know that. Be sure to maintain the flow of the irrigant to keep the urine clear. Exactly. We spoke about that. The fluid in and out. Your NCLEX examination, for example, look at this question, is similar to whatever. Sometimes you get questions to fill out the blanks. A client has continuous bladder irrigation after surgery yesterday. The amount of bladder irrigation solution that has been infused over the past 12 hours is 1100 ml. The amount of fluid in the urinary drainage bag is 1950 ml. The nurse records the client had, and the answer is 850, right? Urinary output in the past 12 hours, fill in the blank. Okay? Best practice for patient safety and quality care. Let me see how much is left for the next topic. Okay. So in this best practice, the most important points after transurethral resection of the prostate is monitor the patient closely, of course, for infection, help the patient out of the bed to the chair as soon as permitted. You have to control the pain, provide a safety environment for the patient, anticipate a temporary change in mental status for the older patient in the immediate postoperative period as a result of anesthetic. Of course, maintain the rate of the continuous bladder irrigation to ensure clear urine without clots and bleeding. And use normal saline solution, which is isotonic, for the intermittent bladder irrigant. Change the drainage tubing frequently for external obstructions. Notify the surgeon immediately if the obstruction does not resolve by hand irrigation, or if the urinary return looks like ketchup. And I've seen that. I've seen that. When caring for an older man who may be confused after surgery, reorient them frequently and remind them not to pull on the catheter. Yes, it happens too, especially on the elderly that have any mental issue prior to the surgery with the anesthesia. They start pulling everything, not only the catheter, but also the IVs. If the patient is restless or picks at tubes, provide a familiar object such a family picture for him to hold distraction. Okay. Critical rescue, and this is good to know. Coming in the exam, monitor the patient for the rare yet critical complications of TERP syndrome. If irrigation fluid is over absorbed into the body, in addition to blood transfusions and bleeding, stress can be placed on the heart. Signs and symptoms include headache, dizziness, and or shortness of breath. The patient is likely to also have hypertension, bradycardia, and an altered level of consciousness. ECC findings include YQRS. At this point in the semester, you should be familiarized with your EKGs, elevated ST, and inverted T wave. Notify the surgeon immediately, as the patient will likely need intensive care while there is, and that's good to know. After TERP, and to know, monitor the patient's urine output every 2 to 4 hours on vital signs, including pain assessment every 4 hours for the first postoperative day or according the agency or surgeon protocol. Assess for postoperative bleeding. Patients who undergo a TERP are at risk for severe bleeding, and you understand why, right? You saw how the scrapping of the prostate is done, or hemorrhage after surgery. Although rare, bleeding is more likely within the first 24 hours. Bladder spasm or movement may trigger fresh bleeding from previously controlled vessels. The bleeding may be arterial or venous, but venous bleeding is more common. So check for bleeding. And another that's good to know, if arterial bleeding occurs, the urinary drainage is bright red or ketchup-like with numerous clots. This is if arterial bleeding occurs. Notify the surgeon immediately and irrigate the catheter with normal saline solution per surgeon or hospital protocol. Surgical intervention may be needed to clear the bladder of clots and stop bleeding. I am taking my time to explain this continuous bladder irrigation because you're going to see this in the hospital setting very often. You need to master this procedure. Don't be scared. The only thing is that you need to control the bleeding and talk to your provider and try to differentiate if it's the arterial versus venous bleeding, okay? If the bleeding is venous, here you go, the urine output is burgundy, with or without any change in vital signs. Inform the surgeon of any bleeding. Close monitor the patient's hemoglobin, of course, and hematocrit levels for anemia as a result of blood loss. One more thing that I want to recommend you here is make sure you have the the bags of the isotonic solution, which is a huge bag. It's a huge. Make sure you have enough bags. You don't want to come across a bag that is the last one you have in your unit, and then you have to change the bag and you don't have more fluid in the unit, and then you are calling all the other units to see if they have extra irrigation bladder irrigation bags. Make sure, because you see, if you don't irrigate, there is a risk for infection if the blood is not taken away, or any blood clots can cause an obstruction. So this is a very risky procedure. If you are ready, it's easy. If you are not, you can cause a damage in the patient. Sexual function should not be affected after surgery, but that retrograde ejaculation is possible. Wearing semen blocks backward into the bladder, so only a small amount will be ejaculated from the penis. Okay, NCLEX questions, take a look and pay attention to that. Interventions, take action. The patient with BPH typically has frequent urges to void and may have overflow incontinence at times of urinary retention. Teach him to keep the surrounding area clean and try to prevent skin breakdown. Remind him to toilet when he feels the urge and, if needed, to wear a small absorbent pad to prevent undergarment soiling. Involve the patient's sexual partner if the patient agrees. Then you have your evidence-based practice information that is very important. Home care management, depending on the procedure performed, so patients may be discharged with a urinary catheter in place for a short period of time. Teach patient not to take a bath or swim to prevent a urinary tract infection while the catheter is in place. Because you know all the bacteria in a swimming pool or taking a bathtub, right? Okay. When the urinary catheter is removed, the patient may experience burning or urination and some urinary frequency, dribbling, and leakage. Instruct him to increase fluid intake to at least 2,000 to 2,500 ml daily. Yes, so you can imagine how big are the bags for continuous bladder irrigation in the hospital. They are very big. I don't remember how many mLs are in each bag. But here at home, they are asking you to drink at least 2,500 mLs daily, which helps decrease dysuria and keep the urine clear. That's basically the objective, to keep the urine clear. Be aware that an older adult who has renal disease, and that's good to know, or who is at risk for heart failure may not be able to tolerate this much fluid. So it's critical thinking. You are asked to perform a procedure. You need to assess your patient. Is this patient having any cardiac issue? Is on fluid restrictions? Check the legs if the patient is retaining fluids. Think about your diabetic patients. All these considerations you have to think about as a good nurse. Self-management education. Some patients, especially those who have had a TURP, may have temporary loss of control of urination on a dribbling of the urine. Reassure the patient that these symptoms are almost always temporary and will resolve. Also remind him that reproduction ability should not be affected by surgery. Help the patient and his family find ways to keep his clothing dry until sphincter control returns. Instruct him to contract and relax his sphincter frequently to reestablish urinary elimination with the Kegel exercises. Okay, and we have completed the BPH section of chapter 67. This is part 1. Let's take a break and we will come back for chapter 67, part 2.